nerve is responsible for vision, including aspects such as visual acuity and visual field perception. It begins at the retina, with axons of retinal ganglion cells forming the nerve, which then passes through the optic canal and into the brain, where it partially decusates at the optic chiasm before reaching the lateral geniculate nucleus and the visual cortex. Damage to the optic nerve can lead to varying degrees of vision loss depending on the location of the lesion. For example, damage before the optic chiasm can result in monocular blindness, while damage after the chiasm can lead to homonymous hemianopia, a loss of vision in the same field of view in both eyes. Assessment of the optic nerve involves visual acuity tests using an eye chart and visual testing. Additionally, the pupillary light reflex is examined by shining a light in the patient's eye to observe pupil constriction, a process mediated by the optic nerve and the oculomotor nerve. Which brings us to cranial nerve 3, the oculomotor nerve. Now, this is the nerve that controls most of the eye's movements, the constriction of the pupil, and maintaining an open eyelid. This nerve innervates several eye muscles, including the medial rectus, superior rectus, and inferior oblique muscles, allowing for precise control of the eye's direction. Additionally, it innervates the levator palpebrae superioris muscle, which lifts the upper eyelid and carries parasympathetic fibers to the pupillary sphincter, which constricts the pupil in response to light. Damage to the oculomotor nerve can result in ptosis, another term for drooping of the upper eyelid, diplopia, another term for double vision, and pupil dilation. The affected eye may be positioned down and out due to unopposed action of the lateral rectus and superior oblique muscles. Testing the oculomotor nerve involves assessing the patient's eye movements by asking them to follow a target, such as a pen, in different directions. The pupil reaction to light and accommodation, which means focusing on near and distant objects, are also evaluated. Cranial nerve 4, the trochlear nerve, is the smallest cranial nerve and has a pretty unique trajectory, as it's the only cranial nerve to exit from the dorsal aspect of the brainstem. Its primary function is to innervate the superior oblique muscle, which depresses, abducts, and entorts the eye. This nerve is critical for allowing the eye to look down and medially, especially during activities such as reading or walking downstairs. Damage to the trochlear nerve can result in vertical diplopia, where patients experience double vision, especially when looking downward. They may compensate by tilting their head to the side opposite the affected eye, a characteristic posture seen in trochlear nerve palsy. To assess this nerve, clinicians will ask the patient to follow a target moving downwards and inwards, specifically testing the superior oblique muscles function. Cranial nerve 5, the trigeminal nerve, is the largest cranial nerve and is responsible for both sensory and motor functions. It has 3 branches, the ophthalmic, or V1, maxillary, V2, and mandibular, V3 divisions. The ophthalmic and maxillary branches are purely sensory, while the mandibular branch is both sensory and motor. The trigeminal nerve provides sensation to the face, scalp, and cornea, and it also controls the muscles of mastication or chewing. Damage to the trigeminal nerve can result in trigeminal neuralgia, which is characterized by sudden severe facial pain or loss of sensation in the face. Testing the trigeminal nerve involves evaluating facial sensation taste testing may be done to assess sensory function, and a Sherman test can evaluate tear production. Now, cranial nerve 8, the vestibulocochlear nerve, has two components: the cochlear nerve, which carries auditory information, and the vestibular nerve, which is responsible for balance. The cochlear nerve transmits sound waves from the inner ear to the brain, while the vestibular nerve conveys information about the head position of movement, which is important for maintaining balance and coordinating head and eye movements. Damage to the vestibulocochlear nerve can result in hearing loss, tinnitus, vertigo, or balance disorders. Testing the cochlear component involves performing a hearing assessment such as the Rin and Weber tests using a tuning fork. The vestibular component can be evaluated using the Romberg test, in which the patient is asked to stand with their feet together and eyes closed to assess their balance. Cranial nerve 9, the Glossopharyngeal nerve, has both sensory and motor functions. It provides sensation to the pharynx, the throat, taste to the posterior one-third of the tongue, and also contributes to the control of swallowing. Additionally, it plays a role in regulating the carotid body's baroreceptor reflex, which helps control blood pressure. Damage to the glossopharyngeal nerve can result in difficulty swallowing, also known as dysphagia, loss of taste from the posterior tongue, and impaired gag reflex. Testing this nerve involves assessing the gag reflex by stimulating the posterior pharyngeal wall and asking the patient to swallow, observing for any asymmetry or difficulty. Cranial nerve 10 is the vagus nerve. The vagus nerve is one of the most complex cranial nerves with extensive functions, including control of heart rate, gastrointestinal motility, and speech. It innervates the muscles of the soft palate, pharynx, and larynx, contributing to vocalization and swallowing. Damage to the vagus nerve can cause hoarseness, difficulty swallowing, and loss of the gag reflex. Clinically, the vagus nerve can be assessed by asking the patient to say "ah" and observing the movement of the uvula, which should rise symmetrically. Additionally, listening to the patient's voice for signs of hoarseness and assessing heart rate variability can indicate vagus nerve function. Now, cranial nerve 11, the accessory nerve or spinal accessory nerve, innervates the sternocleidomastoid and trapezius muscles, which are involved in head movement and shoulder elevation. This nerve allows the head to turn and the shoulders to shrug. Damage to the accessory nerve can result in weakness or paralysis of these muscles, leading to difficulty turning the head or elevating the shoulders. To assess the accessory nerve, clinicians ask the patient to shrug their shoulders against resistance and turn their head from side to side while applying gentle pressure to test the strength of the sternocleidomastoid muscles. Finally, we reach cranial nerve 12, the hypoglossal nerve, which controls the muscles of the tongue. It's essential for speech articulation, chewing, and swallowing. Damage to the hypoglossal nerve can result in tongue weakness, atrophy, or deviation of the tongue one side when protruded. To test this nerve, the patient is asked to stick out their tongue, and any asymmetry or difficulty in movement is noted. The cranial nerves represent a complex and integral part of the human nervous system. Each nerve plays a unique role in controlling various functions, from sensory perception to motor control. Understanding the functions, potential consequences of damage, and proper assessment techniques for each cranial nerve is vital in clinical settings, enabling healthcare professionals to diagnose and manage a wide range of neurological conditions. The intricacies